Thanks for the invitation, Chappie. So really, what matters, what doesn't matter, and I think one of the annoying things is that if you, depending on the population, in your GP, 30–50% of patients will have abnormal LFTs. You can't see the forest through the trees. What do you do and when do you ignore it? And so I thought I'd just give you my sort of view on this. So the scenario is you saw a patient, they just came in for an extra prescription, you just did his blood pressure, you did his LFTs, they came back abnormal, and you go, patient's left, what do I do? Basically, so I thought I'd just run you through it. Now, the tricky thing with liver function test, it actually doesn't measure liver function at all. This is either liver irritation or it's bile duct irritation. It doesn't tell you crap about what the liver itself actually does. So we've got ALT, AST. These are enzymes that are present in the liver, but also in other organs. And then when the liver cells die, they get released, and then we can measure them in the blood. GGT and alkaline phosphatase, they most likely live in the lining, in the bile duct, so anything there's irritation there, you can get what's called cholestatic liver function tests. The problem is these enzymes are present in so many different other organs, so if there's one elevated just by itself, it may not be the liver. If they're elevated in combinations, quite often it gets more likely that the liver is involved. But they're not really liver function tests, it's either liver or biliary inflammation or obstruction. So what is really a liver function test, and that's the main thing that I'm interested in, is if tests come back, what's the INR? Is the liver still making all their proteins to make sure they have correct coagulation? And the other thing is serum albumin, because albumin is exclusively produced by the liver. The problem is albumin goes down if they've got an infection, if they're unwell, lots of other comorbidities, so sometimes gets a bit hard to test for. And the other thing is we've got so many people now on these fancy new anticoagulants, and they all sort of affect the INR as well, so that's the only thing is that sometimes it gets a little bit tricky to interpret. So again, ALT, mainly hepatocytes, released when cells are hurt or destroyed, normally sits around between 5 to 40 or 50, and then the question is what's relevant. So if you call me up saying somebody's ALT is 100, I go, yeah, that's all right, we'll maybe do something different. If you call me up and saying, look, the ALT is about 300–400, I go, that's quite interesting, because if it would continue, so anything like around 100, you can think, it's a bit of fatty liver disease, maybe in a few years' time something can happen. But if you're having sort of up to 500, you go, actually they're burning through liver cells pretty quickly, so this is quite interesting. And if you're telling me their ALT is 1,000, I go, holy crap, let's do something really, really quickly. So that's sort of my level of thresholds, what I'm sort of looking at. So AST, now most of the time you'll order a liver function test and you'll get ALT back, and the advantage of that is it's a longer half-life. In hospitals, when patients are really sick, we quite often do AST because you get really beautiful daily variations, so we can see much faster if they're improving. It's also found in liver, heart muscle, intestine, pancreas, so lots of other different things. And sometimes we use it if we suspect it alcoholic, but in reality, quite often you know who's alcoholic and you can just ask for that. The only thing is that particularly the Americans, they love doing things differently with gallons and pounds and miles. So quite a few of the calculators use AST rather than ALT. So cholestasis, so you've got GGT. The problem is it's really sensitive and not very specific. So sometimes you can see it in biliary outtrack flow. You can also get it with alcohol, and sometimes it's useful to manage compliance. So what's relevant? You call me up, the GGT is 200, I go, oh yeah. It's 500, I go, yeah. It's 1,000, I go, oh yeah. So isolated GGT means jackal. Nobody's died from a GGT of 5,000. So it basically doesn't really become relevant. The only relevance is that if it's basically my pearless GGT is useless, sometimes you can use it in combination with alkaline phosphatase. So if your GGT and alkaline phosphatase are up, that's a great idea that something's happening with the biliary tree. But you can also find it in bones, intestine, placenta, or when people are pregnant. So it can rise with obstruction disease, stones or tumors. So alkaline phosphatase around 100, I go, oh yeah, just do an ultrasound, do another blood test in a few weeks. Really get quite interested when I get around 500, and same thing when it gets really high, I go, oh yeah, really got to sort of work pretty sort of quickly on sort of getting something sorted. So if this is not a liver function test, well, what is liver function test? And that's one we're saying, well, once somebody's got acute liver failure, we're really looking at INR. So the INR normally needs to be greater than 1.5, and usually we also start combining this with encephalopathy, so the liver can't get rid of the toxins and the ammonia, and people get a little bit confused. And for an acute liver failure, we're saying they need to have no other liver disease, whereas in chronic liver failure, they need to have sort of cirrhotic. So, well, what do we look? Liver failure, you probably don't really see it very often, but quite often when people have got what we call hyperacute paracetamol overdose, acute sort of viral illnesses, people can get really quickly, but most of the time people get better pretty quickly, but sometimes they need ICU. The problem is when you've got like a very bad hepatitis and then they present 6 weeks to 8 weeks later, then quite often all the liver cells have died and you're just seeing jaundice and liver failure, and actually outcomes sometimes can be quite poor. So what's my approach to liver function test? It gets a little bit tricky, and the thing for that is that I always look at the predominant. The problem is if I've got biliary blockage, so even there's like a gallstone or something sitting in there, the liver cells will get dysfunction because they can't get rid of the bile. So it's usually hard that only one is up in isolation. So I'm going to say which one is predominant. Is this predominant a liver problem, or is this predominant a bile duct problem, a cholestatic problem? So if the ALT is 500 and the alkaline phosphatase is 200 or 300, I go, this is predominantly a liver problem. You can get isolated bilirubin, pretty common. 5% of the population has Gilbert's disease. That can be due to hemolysis. They can't get rid of the bile from the blood cells. So if it's just the isolated bilirubin, you normally can ignore that. And most of the time what you'll end up with mixed. So step one, is it a liver bile duct? Is it a liver problem itself, or is it a bile duct problem? The second thing I look at is a new or a long-standing problem. And really the history and the patient profile is going to decide what's most likely. For the other talk that I done on liver test, we had lots of things, and the only thing I changed was the topic or the age or the presenting complaint, so they're really non-specific. So it really comes down to a good history. Did they take any new antibiotics? Did they take herbal supplements? Really, that still comes back down. And then the nice thing is it's a pretty standard thing. You can just do a liver screen, look for viruses, autoimmune problems, check the INR, do an ultrasound, and then the main thing is if you're concerned, you can always refer back to your friendly gastroenterologist. And that's my short liver talk.